about, when you do your nebulizer, you go off the wall. You were taught to go off the wall, which is great because you get a little FiO2 extra. But then you'll see that your neb cup would always be, there would be residual left over. And why is that? Well, two reasons. One is the way the cone is designed. If you look, there are two gills on here so it exhales your CO2. But you don't see the mist. If you saw that on the MetaNeb, you had mist. You don't see that on this. Because of the cone, it comes back and it goes back and it rains back into your nebulizer. So that's why you see excess. Now, do you get the 10 minutes of your treatment? You do get full medicine distribution of the required dosage. Still go off the wall. That's an awesome thing to do. Because, but now you're new, as you're going to see when you order some circuits, you're going to see a different nebulizer cup, which is a little closer to the top here. They took out an adapter. Okay. So you won't have leftover.
Yeah, the distance is what was creating that leftover medication in the
so
cups.
So we went through the approval of that. So, yeah.
Okay.
All right. Easy peasy?
Mm-hmm.
Easy peasy. All right. If you don't want, now, people do and don't, but sometimes you will do a spontaneous breather without a nebulizer because they don't like it. And then they complain that their mouth is too dry. But then you can take the plug off your cone, stick it in here, and now you can do a spontaneous breather without a nebulizer. Okay? There are those patients,
Cool.
they're fuzzy, they're just
Fussy.
Fussy. That's what I'm thinking of.
We don't have those here.
We don't, yeah. So, to start the device, turn it on, and then in the hospital setting, we're going to use manual. Home care, now we are working on a CPT code. Once that CPT code happens, right now when you have this device and you have a patient that could use this device long term, that's where you call Chris and you get the paperwork from him. They do a prior authorization. Because we're still working on our CPT code, the HCPCS code, Hillrom, just a little history fact, is Hillrom was the first company that got the HCPCS code for the VES device. It took 5 years. We were hoping it would take a little quicker because of COVID being a respiratory, but a lot of people were told that they couldn't use nebs, which you could have used the Volera. Yeah. So, you see what I mean? So just a little thought there. If that happens again, you still can use the Volera.
Cool.
Just put a plug in it. But know that we also have a study that when you do the nebulizer, it drops on a spontaneous breather within 12 inches of the patient. So you're still going to be fine. The vent is it's a fully closed, and we'll go through that. Okay? So I'm going to, I have a spontaneous breather. I go off the wall. I drop my nebs in here. I do not put antibiotics in here. I put hypertonic saline, albuterol, but no antibiotics.
Okay.
You do that after the treatment. We're trying to open up the airway. Do it after. Cool?
Mm-hmm.
How about a mucolytic, like a mucomist?
Yep, mucomist you
Okay.
can do. Does your hospital order a lot of that?
Mm-hmm.
Depends.
Okay. I have HCMC Minneapolis for some reason. I think they have stock in it. They order it on
We have
every
stock
patient.
in Sopanites.
Soapanites, yep.
Okay.
Do we rinse then after mucinex because it's so sticky?
You can, but I don't like rinse this out. You can.
I would.
Or any
yeah.
of that?
If it's that sticky,
Yeah.
I haven't had anyone complain about it.
Okay.
But
Okay.
so
You were laughing too
when
hard
you
at
hit
that.
on, when you hit the manual, you'll see that it automatically chooses your nebulizer. So we know we're going to turn that off. Now, your lung expansion, oscillation, right? That's how and we were taught to go 2.5 minutes, 2.5 minutes. But this is what's great about this device. We put it in you. You guys are the drivers, because maybe some patients don't like the 2.5 minutes of lung expansion. Maybe they can't tolerate it. So we'll start on lung expansion, and usually for an adult, this starts at 5, it goes up from, or low as 5. high as 25. Usually we start between 12 and 14 on an adult. Okay? So, as you see, nothing happens, right? I have to turn.
Thank you.
Yeah.
What was it? You start at what, 12 to 14, right?
12 to 14 on an adult. On a, you do peds?
Mm-hmm.
Peds are 10 to 14.
Yep, we did.
And we would never do this on like a neonate, right?
You can. It's
I'm not gonna suggest it, but
I don't know that we would do this on peds here. Our peds is more of an observational.
Oh, yeah.
Than
I would
anything.
use a mask.
Yeah.
okay.
Yeah.
But with rhino and flu and RSV, we might.
Oh my gosh,
Yeah.
5 kids,
They don't let us do
5
anything
kids this weekend.
down there.
Yeah. Okay.
Send them next door. There's a PICU at St. Vincent.
Your oscillation, your you know, it defaults to 50. It actually, that's where we lock you out as 50. It actually goes up to 70, but there's no reason why.
Okay.
We did that to mimic IPV, but you're never going to go that high. You're going to start, usually, depending on your patient, for 20, 25. So I'm talking, I was trained by someone who's a little bit of an aggressive therapist, Amy Hickerson, and she starts at around 25, 20, 22, 23 on your oscillations for a spontaneous breather. What you're looking for is what? Chest wiggle. We're looking for chest wiggle. So if you get chest wiggle at 22, start at 22. But we want the quality of chest wiggle, right? So I'm going to turn on the device.
It's also all about technique, teaching your patient.
Yep.
As far as
So once we turn on the device, it's a blower, right? So this is where you put the patient's mouth around the mouthpiece, and like Sandy said, we work on technique. This is all technique driven. If you have bad technique, you're gonna have a bad, not bad, but it's gonna
Fancy
be
med.
a fancy
Right.
schmancy med. So now we're gonna start. We just turned it on. We're just having the patient, and right here it shows the time of the total treatment time. We haven't started anything yet till we hit the button. Now we talk about the patient. Take big breaths in, out, breathe normal, try and relax. And they're going, oh, I got an air compressor down my throat. You just wait, just take it easy. And you might only be on this for 15 seconds, then you're gonna hop over to oscillation. And you're gonna have let's say you don't see any chest wiggle, now you can turn it up. Oh, now I see chest wiggle. They can feel it. Keep their teeth taut on the device. If they're using a mask, make sure it's sealed.
And you want to just make sure that if the patient's taking the treatment through a mouthpiece, their cheeks aren't. If
You're gonna
that's the
see that.
case, that's not. You want them to almost bite down on that mouthpiece,
Okay.
and hold their cheeks in, and then you're going to see it here.
Yep,
No puffer fishing.
yep, no. Yep.
Okay.
Now, we have 3 oscillation speeds. 170, 230, 300. So, we traditionally start a patient on 300. Or, I'm sorry, 230, medium. If they can't, this is slow. A lot of people don't like that because it's a bigger recoil. You're going to see most people sit between medium or high. But I would start in medium so you have somewhere to go. Now you're talking them through. Now we go back, and now this is a welcome break. They were bitching before, right?
Right.
And
Heck
now
yeah.
this is like, oh, thank God. And that's where you go back and forth. And up here you will have stages of your time, and then your total treatment time. I would document your stages of how much time you're at each level, and then you can go back to oscillation. Once again, we're looking at technique. We're looking at good chest wiggle. You're looking at their saturations. One thing we do not have on here is what if they start coughing. Okay, then you're going to have to hit stop. There's no pause on manual. Let them cough it out. Just remember what your time was and go back. On the end, you'll have to, if you use 70% of a 10-minute treatment, so 7 minutes of a 10-minute treatment, it will count. Why do we have that? Because the smart filter knows it's 90 treatments. Why is that? For home
Okay.
Because we want to make sure that our patients, you know how patients that go home, they never change out anything.
Yes.
This forces them that
Yes.
after 90 treatments or 30 days, they'll get a new circuit.
Okay.
But it's a good, for you guys, a visual aid as well to see how many times. CF, Minnesota, do you see CF patients?
Not
Rarely.
as much. That's mostly next door.
Okay, because they change out every 3 days. They change out a circuit. Traditional hospital policies that I've been having throughout the 5 states that I cover is 5 days. They get a new circuit. So you'll never see the 90 treatments, but that's for home. But that's hospital policies that we see around. Okay? And this right here just shows your max and minimum. Yep.
So, any patient that we have on this, that smart filter will tell that machine how many they've had.
Yep.
It's
Cool. Okay.
It's just
As long as you've used over 70% of the treatment time.
Got it.
okay.
You could also go back, but
Okay.
if you turn this on and turn it back on, or turn it off and turn it back on, it's going to remember, just like our Vest device, it's going to remember the last treatment. So if you go to Mary and she's different, and then you go to Bob's and you sign him up, this will just show the last treatment, whoever used the last treatment.
So one of the things that so what Karen is saying is if you move this from room to room to room,
Right.
We do.
when you find that sweet spot for their treatment, you can program it into your automatic mode. And what I would suggest doing is putting the patient's room number there. So 203, and then the settings are pre-programmed. 207, this is what they use.
Yeah, but
So-
you can't adjust it then.
We currently
They're
can't get into
locked.
into an automatic mode to program anything.
Yeah.
Really? Yeah, we're all
No,
locked
I saw
out.
you're locked out.
Locked out.
Yeah, they're locked
Which
out.
I think
because
is
of
what our
reasons.
issue has kind of.
Yep.
So then just make sure you have clear documentation on
Yeah.
what patients that, what room, their settings, that kind
Yeah.
of stuff.
I don't
Okay.
know if you have someone here who's been here longer than a week or so, I can see it going in. It's a fine. That is going to be a discussion that you guys need to talk about, whether you're automatic. The automatic mode is kind of nice because it does give the patient. It gives the patient the view of what it looks like. So it's like following the bouncing ball. Instead of you manually going back and forth,
Oh yeah.
you can program how many seconds, how many minutes per each one. You hit start. Whoop! I didn't mean to hit off. Sorry. You hit the.
That was easy.
So the smart filter doesn't remember their settings. It just counts the days. Or the
It just
time
counts-
used.
Yep, the time.
Okay.
You can go
Got
back
it.
in the history, but then you're going to see everyone's history, and then you're not going to know which one. That's
Okay.
why it's up to you to document.
Got it.
And that's why we give you the autonomy to be what you guys are, and that's RTs. You are the experts, so you know your patient. If they have mucus, especially we're seeing with the COVID's a very thick, sticky. We're seeing that really low in the lower lobes, and we're seeing that you might have to go a little higher on the pressure. Okay, to get that good chest wiggle. When you're done with your therapy, please, please, please try and get that patient to cough. I don't care if it's a or a bear growl, something, because it's a physiological effect, right? We have lung expansion, opening up the airway, and then you have the oscillation. It goes behind those mucus plugs, brings it up to the bronchi. Now, if we go, okay, treatment's done, bye, what's going to happen? Gravity. It's going to go right back down, and we defeated the whole purpose. So have them cough, have them try and get something out, even if it's very small. You'll be surprised. Pneumonia patients, we're not talking just COVID patients, pneumonia, MS, spinal cord, traumatic brain injury, multitude of patients, MD. Anyone who has a respiratory where you want to move those secretions out, open up those airways, and want to do bronchial hygiene, this is your guy. Okay? Spontaneous breathing, right?
After surgeries, those kinds of things.
Got
so,
it. Alert. Okay.
I forgot my little dealie. Let's see.
The other thing too, just like when you're giving an treatment to a patient, have them every so many breaths, 4 or 5 breaths, deeper breath in, deeper breath out. Same
Okay.
kind of thing.
This is your. Well, as you see, you have. I pulled it off. I have it something out where you get on your blue cone is
Yep.
for vent patient only. You do not do CPAP on your manual mode. You will not do CPAP, right? Because you're gonna increase your FiO2 on your vent. Now, there's a couple things. One, you automatically have this on here. Today I don't, because I was at a show and I had my lungs going.
Okay.
But that will go right in T-line. You have to use a T-line spring adapter to your inspiratory limb. Put that on, cap it. Look at what their peak pressures, the peak inspiratory pressure is. What is it at? If it's at 22, you're going to start 5 above. That's your beginning. You're going to start at 27. You're not going to do lung expansion. You're
Okay.
just going to do oscillation.
Okay.
Now this is where it's a blower. When we have the blower on a vent patient, we're diluting because it's a blower. There's no FiO2, right? So
Sure.
you increase your FiO2 on your patient on the vent.
What percentage do you suggest?
It
Just
So
right
we're
Yeah,
saying
just
this
the
is
right
What we did.
Yep.
So this is in training room air, diluting, FiO2 delivered to the patient. We have to compensate
Whatever you
by
need.
increasing to maintain the SAT.
Yeah.
Yep.
Got it. Okay,
Yep.
cool.
Yep, because you're going to see the saturations drop. 2 reasons. One, because we're diluting air.
You know what I
2,
was looking for.
possible. And the other, mucus plugs.
Sure.
You're going to see that too. So we're going to go in, we're going to turn it on, and we're going to turn off the nebulizer, and we're going to start our oscillation. And we're going to see our mucus, we're going to have good chest wiggle. If we don't have good chest wiggle, then we start up. Now what's cool is the blower, that's where your precise pressures comes in. It's always going to maintain the precision of the pressure. How do I know? So let's say I have a patient, a bronchiectasis on the lung, or it's on one side. Now, it's still getting the pressures, but it's not overinflating all my good parts of my lung, right? And we're getting good chest rhythm. So as that opens up, we maintain the pressure. The device will maintain that pressure. When it goes up like that, now, what people forget is they're holding it and they're waiting for you hear the blower? The pressure is trying to compensate for this. Hello. So you have
That's
to
great.
occlude and get your pressures up to 20, so where am I, 27. And I wanted to show you that, 27. If not, this is what you have. You have 3 seconds.
Okay.
And then you have a caution, a biofeedback caution. That doesn't mean you did anything wrong. It's a default
Because there's a leak.
because there's a leak.
Okay.
And it's a default 3 seconds. Usually my thing doesn't pop. In my
I
hand.
really enjoyed it. That was, you should do that every time. I really paid attention.
You're like, what the hell?
Big time.
So,
Yep.
yeah. So just
Check
know,
this out.
I turn it on. I turn my CF on. I occlude it. I let it ramp up 8 to 10 seconds or so, depending on where you are. I have my FiO2 increased on my patient, and then I put it in. Now, you might also see that the patient might be destatting, or like let's say they're at 92 and then they drop to 82. Why? It could be also the function if you have volume on and not pressure on your vent.
Okay.
That will be a change or two. You maybe want to change it because this is pressure, not volume. And that will, if you change that on the vent, then you get more precision. Then the vent won't be like, is this person breathing? What's going on here? When am I getting double breaths?
And that's why you suggest pressure mode ventilation for therapy, not volume.
Correct.
And then we go, if we're in volume prior, we switch to pressure. go back to volume after therapy.
Absolutely.
Okay.
And you'll see great. Now, do you guys use Aerogen?
We do.
Continue.
Okay.
I would use Aerogen. You could do this one and put your nebulizer in there, but it's just weight. You don't want that. So just use your Aerogen. That's great. What you're doing there. Easy peasy.
Yeah.
And I'm not even cheesy.
So when you're
It's Wisco. We like cheese here. Load it on.
Yeah, lemon squeezy.
so when you do
I
it
like
with the
cheese
ventilator,
better.
you're gonna hold it to get to your ventilator before you put it into your spring valve.
Yep. If
Okay.
you don't do that, your vent is going to go nuts, and maybe you get right underneath that percentage where it doesn't, but then you're going to decompensate that patient.
Okay.
What did you ask?
So you're gonna occlude it
You'll-
before you hook it into your T.
Yep.
Okay.
So it
So
can
you
build
occlude
up.
it, you build up to your pressure, and then when you have a little bit of time, like, because obviously you're gonna take your hand off, and then
Yep.
okay.
Yep. Traditionally, what we have is when you have it occluded, you can pop
What?
it off and put
I
it
know.
in.
Quick hands.
Yep, quick hands.
Well, we also left it in volume where it was like.
That was the issue. That was the problem. Yep.
Yep.
That's what we
That's
did.
a big. That is where I've asked. So we're part of the leadership board, and asked to have that change in the manual. That
Yep.
when you're on volume, you go off because this is precise pressures. We're looking at pressures, and you're going to see it better with the patient. And I would also include that increase your FiO2. If it's a through the university, you have a donor patient, and you're doing this, it's Q4. Then you're gonna do 100% FiO2, but you're gonna do pressure, 10-minute treatment.
They're asking for that for donation?
Yeah.
They might.
Organ donation?
Yeah, so they
Depending on-
usually
You know we do
do.
CPT.
Yeah, you usually do the Metaneb, and now that hospitals are converting because the Metaneb went bye-bye. This is the predecessor of it. We took the Metaneb as of December 31st, 2021. We can't sell, repair,
Yeah.
right? So this came out 2 years ago, a little bit over 2 years ago, just before COVID. It came out, and it's a game changer when we look at precision of pressure and we look at lung expansion. We're looking at the whole lung recruitment. You want airgen, bronchial hygiene. After your therapy, what do you do on a vent?
Suction.
Yes. If I had money, I would give it to you. $10.
Yeah.
I forget,
I won
when
money
you're
today.
done with the treatment, you
On
still,
Danny's
if you're
thing,
taking it out,
which
you
is
want the
like
machine to be running still, right?
$20.
You want the Volera to still be on, you
Yep.
pull it out of line.
Yep, when you pull it out of line, let it run, it'll ramp up, then you can turn it off.
I couldn't remember if that was the case or not.
Yeah, because some people, if you turn it off and you have it in line, what did you just do? De-recruit. Because now you have another limb, but it's trying to get air to it. So you just pull it off. You'll hear the ramping go up, then you can hit off. Even if it goes up it just gets just loud. You'll hear the blower. Now, as you hear the blowers on, after a couple minutes, it will turn off. If you have it on.
Do you also keep it in medium frequency or?
So it all depends. The frequencies, we're doing studies on that now. It is just a tool in your toolbox. It's a lot of times it's comfort for a spontaneous breather, and sometimes RTs, they're staying there for 10 minutes and they get bored, so they switch back and forth.
Okay.
So does it help?
To me, it's like, I just used it, 2 or 3 weeks ago, I had COVID.
Yep.
And it worked great. But I was playing with it, as an old RT, so I looked at the oscillator, right? We have the oscillator. And I looked at the hertz and the frequency, and I was like, the lower the hertz,
The 170.
shake.
Yep.
More
the bigger
intense.
tidal, it's a bigger tidal line.
Sure.
To
Yeah.
me. And then as I go up, it's a smaller tidal line.
'Cause it's
way more
It's happening
comfortable.
more often.
Way
Yep.
more comfortable at the higher. The middle one was probably for me,
Go-to.
was great.
But
But the low one, I didn't.
not that many people
If you have
stay
a
at
crabby
the low.
patient, go ahead and
Not
try
that
it.
many
It's a
people-
big tidal line.
It
It's
is.
like, it's just, and then it's.
That
Okay.
recoil.
But the middle or the higher one, I kind of like the middle one because it was a bigger thump, than the little ones. But But
And
it
to
was-
talk about also muscle memory, if you have a patient that comes in as a longtime vest user,
Yeah.
let's say they've been using the vest for 15, 20 years, and they're bouncing back, use the Volera. Why? Because muscle memory, they're getting extrinsically. This is intrinsically. They're going to see a difference.
Internal CPT.
Yep, and it's great. Then you call Chris up, and they do a prior authorization. Once we get that HCPCS code, it's going to drop a lot easier. If you have a VA patient, this is on the VA contract with the vest device, so you can get without a lot of hiccups. You can get that device for a VA patient. You just call Chris. Or
So in conjunction with the vest,
Yeah.
you're saying?
You have to
Well,
apply.
Or
You-
instead of?
or-
yeah, or-
instead
Well, the
of.
VA
alternative.
can do whatever they want.
Sure.
Right.
yeah.
So VA can order 20.
But a lot
whatever
of
they
people
want.
don't like one if they have one arm, or if they now have a belly barreled chest, they can't get that wrap around. If it's a lady and they're a little welded, it's harder to get it around. If they're kyphotic, that's another issue. You know, in time.
Sure.
So there's a multitude of, if they have a pacemaker, you know, there's a lot of things involved where intrinsically
Yeah.
this is such a game changer. So I tell you this, our other account executive, her name is Amy Hickerson. Her husband has MD. She's allowed me to tell the story. So he has MD. He does this twice a day, and he's at 37 on oscillations because he's now he
Okay.
there's a lot of things he can't do,
Sure.
and he's losing. So he loves this because it's getting it up. Now, as his cough is starting to go simmer down and he's not able to get it up, then we're introducing the Sinclair, which is our cough assist. And that is really, that's a whole different story, but just to know that we have the Volera and the Sinclair is for evacuation, and
Okay.
that took over for the vital cough, is the
Okay.
Sinclair. Once we get a HCPCS code, we're looking 7 years down the line, we're gonna marry those two together. So you'll have a Volera, which does bronchial hygiene,
Right.
and you'll have the option to do evacuation and the same treatment. So just to keep you amazing. Then you're not shuffling around two devices. So
But we do have a cough assist, so if you run into patients that would need that for at home and you're struggling with getting that device because
Yep.
of the recall,
it's the Sinclair.
just know that we have that option for your patients.
And currently, we just rent it when you did it.
Yeah.
Yep.
But
And-
if you had a home patient.
So
yeah,
on your facility,
Well,
if
and
you
if
need
I
to
do
rent
this,
one, you can rent a Sinclair, or for $15 a day, Volera, $15 a day.
Okay.
A vest is $15 a day.
That's nice to
And
know.
then the Life
We
2000.
sometimes have multiple people
Yep.
on the vest
You guys
instead
seen
of
those?
No.
rolling
And what's
around.
nice about, let me just,
we
before
did
you get
see-
into that,
We tried to get it for one. Is this the
For
one
that-
that we tried to get it for that one patient?
That girl who had
That-
the
but
transplants,
yeah.
something.
so I just,
she ended up needing more and ended up down in UW.
before we start on that, I just wanna say,
Yes.
with your patients, now I lost my train of thought.
Oh my God.
I know, shit. Oh, this is what I also wanted to say.
I could play
We're
that.
seeing with spontaneous breathers, now it's flu season, right? They anticipate flu season's supposed to be a big whopper. The
Yes.
show. Yeah.
Oh my God, yes.
So we
Can't
had a
beat that.
football player in Ohio State. He came in, both lungs were completely whited out. He walked
Whoa.
into the ED.
Yikes.
They did a bronch on him every day for 30 days. And on the 30th day, before the bronch, well, 29, because on the 30th day, the RT says, "Why aren't you using the Volera?" And they go, "Well, let's try that instead of the bronch." They did. And that next day, they did a chest x-ray, and his lungs were half cleared on one treatment. The reason I bring it up, yes, he's an anomaly because he was an athlete and he had double pneumonia, so he had low bore respiratory recruitment, is that this can be used in your ED, can be used on every floor. I know it's a lot for you guys to ask, but it's a 10-minute treatment that makes a difference. And if you get these patients out, your time is going to be lower, right? Isn't it called spend money to make money?
But
True.
do therapy to get less patients.
Well, and it'd be nice to prevent escalation.
Absolutely.
Because
And
that's
that's a
what's
huge thing.
happening is we can't get it out, their mucus plugging, now they have to go to ICU, now we're gonna bronch, now we're gonna do all this, where we could have at least
Avoided
started
it.
something. Yeah.
And we go back to the technique. You guys use that person, they're like, oh, 10 minutes, I can't keep my mouth shut for 10
Right.
minutes. Or I can't bite down for 10 minutes. Well, you know what, then we're gonna put this on you.
Mm-hmm.
And you're gonna hold it. And you can hold it for 10 minutes. And then you get a nice big seal. And now they, especially with the non-compliant where they're always, but let me tell, no, that's good seal.
I like
Right?
that.
And then, yep, you got peace for 10 minutes, just kidding.
No straps, cause it's asphyxiation, right?
Right.
Like, we're not allowed to do that, so we
Right.
can't make any, even though
Yep,
people are
can't
gonna
put straps
wanna.
on this, I know, or can't use tape, don't tape them
No
down with duct
Coban
tape.
then, you're saying.
Oh.
We know
Yeah.
I pat mask Coban done, but
No
not long
bungee.
ago.
You can
No
glue it on
bungees.
though. Glue's
So
fine.
when they're doing the mouthpiece, do we do a nose?
No,
picture?
so if their nose starts itching, that's good.
Okay.
That means they're getting good chest wiggle.
Oh, okay.
Vibration goes into their nose and all of a sudden they're like, my nose itches.
Okay, so don't plug their nose.
Nope, that's a
Okay.
good sign. That means we're getting good chest wiggle. If they're doing everything and you could see in their, like right in their neck area,
Okay.
the chest, but you can also hear a chest wiggle. And that, you can hear that.
Yes.
If you're not getting it, especially if their cheeks are going like this, then sometimes we've had where you just hold your cheeks. Yep. And then you keep it taut. And then they'll feel it down here and they'll go, oh my God, that's what we want. That's what we want. It's great. It's a game changer on therapy.
All right.
So what are both for spontaneous and vented? What are the contraindications?
Not treated pneumo is the contraindication.
That's it.
Yep. And we've
Okay.
had
Sweet.
patients where they get a chest tube, they get the Volera. We have a study that shows also thoracic surgery, cardiac thoracic surgery, 2 hours post, they're doing a Volera treatment. Why? Lung recruitment.
Yeah.
The lungs are so sensitive. And if we don't do it, they're gonna stay longer intubated, longer in the hospital. We're seeing a quicker recovery with it. So 2 hours, they're doing a BID or depends on the physician, but you can do BID or 4 times, 3 times, whatever you guys decide.
All right.
Okay. Question.
something?
So we had a patient who didn't have a lot of chest wiggle because he was more of an abdominal breather. So aside from chest wiggle and chest x-ray, what am I looking for to know that my treatment is effective?
Saturation, how they look,
Okay.
how they're breathing. I would also listen.
What you're suctioning
Remember
out.
that one
Yep,
day we
what you're
did
suctioning
that
out?
and like we couldn't hear it.
We
first
couldn't
time,
hear it,
and
but that's
then-
also because he was a vented, we were doing it he was vented at the time,
Okay.
but he was still more, it was all
And then we turned it up. and
abdominal.
then
We
you
turned it
could-
up, we could hear it a little
Yeah.
bit more,
How,
but
Yeah.
how high did you turn it up?
see, that's the thing, we were only at like 20.
Oh,
Yeah, we
Very
thought
low.
we were.
so just to
Yeah.
give you a
He
little
was a
history,
big guy too, big
Yeah.
belly,
Yeah,
big.
ARDS and stuff.
Metaneb, it was entrainment, and we knew that in the front there's a little area where it measured up to 30 centimeters of water pressure.
Okay.
But we found with oscillation, and I have a documentation, we have a study that shows it only gets up to 22. So you're getting a glorified neb.
Okay.
Now you're not with precise pressures. Will you get it up there? Sometimes I had a patient at the University of Minnesota. He was at 49. To get good chest wiggle, we went up to 49. Now, as he got healthier, we didn't keep it at 49, we brought it back down.
Mhm.
But then we bring it down, but still maintaining the chest wiggle. Once he got off the vent, then we did it spontaneously, and he went down, and he was usually riding around 29, 30, 31.
So when do you go up on, so you go up on the CHFO for chest wiggle, when do you go then up on the CPEP? Or do you just always start between the 12 and the 14?
Yeah, I mean, on an adult, and
Yes.
it just depends on it. It also depends on your saturation level.
Okay,
You know, if you're dropping on your
That was 20.
okay.
yeah. So it's tolerance also. You're opening up that
So we'll work out.
So tolerance, okay.
And the first thing, and that's what, when you start your treatment manually and you're on on your CPAP on lung expansion, and they're like, holy crap. I hear 90% holy crap or holy F.
Mm-hmm.
You're trying to blow me away. And you hold it down, no, and then go to oscillation. And then they're going to change, and they're going to go, and then now it is work. This is therapy.
Right.
Right? So they're going to work, and then you go back to here. And I'm telling you, it's a nice walk. Also, they're like, oh, I can tolerate this now. Well, you were just bitching. No,
Yeah.
Right, right.
But now you can tolerate, and that's the
Oh,
big
now
thing.
it's not so bad, huh?
Yeah. Yeah. Did we answer all your questions?
Yes.
She'll have
She's
more. She'll have
pleased.
more.
She accepts.
Awesome. Just know you
Wow.
can't put in another, if you wanted to, if you had someone who's really goopy
Mhm.
and you want to put in another filter, you can put it in up here.
Okay.
Have I seen it? I've seen it. I've seen people put it up here. You can put a different mouthpiece. You guys can all use one circuit and go on. We can't do that anymore because of COVID, but. I
Because
know.
you don't,
Right.
you don't need to use a HEPA, you don't
Yeah.
need to use a HEPA filter or anything because it's their
Nope.
own circuit.
That's this. Yep, this is great.
Okay.
Are you on our vent patients? The same thing. You're not going to be on it long enough to get any rain.
Okay.
That's going to be great. If you do, call us. We'll go through it. We're probably missing something.
Can they hawk a loogie up in there, that circuit? Like, could it?
Pull out, but
Could
yeah.
have traveled
Yeah.
Yeah,
that
they can.
direction.
Okay.
They could.
So they're not rinsable, correct?
So they
Yeah.
had to call for that hard.
You can rinse it out.
You
Take
can
it
take
out,
this off.
wash it, yeah.
Take this off,
Oh, but it does come off there. Okay, cool.
and you can rinse it.
Yes.
Okay.
Yep.
Soapy water, whatever works.
Yep.
Whatever.
Excellent.
Yeah, if they hawk a loogie, and especially, and if you have a,
Yeah.
if you have this, you can always take this off and look and make sure it's clear.
Okay.
But make sure when you have it locked, that you lock it. A lot of people, they put it on and then it's not locked and then it flies off.
And
Yeah.
you do feel that air come off of that little section. Curve
the gills?
CO2
For a
retention,
spontaneous,
correct?
yeah.
Okay.
So you don't want to sit behind there, right? And get there. You don't want to be like, what's going on? 'Cause
Yeah.
right?
Yeah, no.
But I always
So-
do that. I always suck on the other side of nebulizers.
Right.
It's something that we do.
You gotta get a treatment
That's how you
too.
stay
Right.
dialed.
What?
Right?
We're minimizing
What?
waste.
And that's how
Go
I
green.
suction.
Go green.
What?
It's like
Till
the
you
baby
trigger a
thing.
cough.
No gloves either, right?
Well, of course not.
Right. Can't afford that. Oh my goodness.
Now,
Wait,
here's the
here,
thing. If a
are you doing
patient,
okay?
if you have a patient that is going home and
Isn't
they're
that big?
qualified and they're getting one of these at home, let them have the circuit.
Okay.
They piss
know.
me.
How much are they?
So your hospital, I know it's $94
No, for a
At home.
machine.
for the circuit.
for the
For the
machine.
machine, it's $89.50.
$89.50.
Yeah.
Per
The
That's what I
minute.
circuit
was
costs
thinking.
more than the machine does.
Yes.
No, circuits are about $100, yeah.
Okay.
But the,
And the machine is.
$8,950, but it all depends. I know that's what
You
you
get the
guys.
cart with it?
Yes,
Basket?
yes.
Hey,
Those are good questions.
those
Yeah.
are because
Yes,
remember
yes.
that one that we the basket's separate.
Oh my gosh, when we ordered those vents.
Mm-hmm.
Well, when we got
Oh,
that
like
vest
Wilson's?
from that guy,
Mm-hmm.
who had to buy the cart,
Yep.
I had to put it on the cart.
Yep.
Which vent did we buy? And like
Avia's.
all these, we were taught all these extra like modes and cool things. And oh, you gotta buy that.
The
Oh, you gotta
Pearson
buy
Bennett.
that. Oh yeah, Pearson Bennett.
oh, really?
Yeah.
add-ons.
Yeah. Yes.
Suckers.
Right.
Same
And totally
thing with the
like.
Hamilton.
I was just
Oh,
gonna say about the Hamilton.
want,
Oh wait,
uh,
the non-invasive. That's a
Well, and
separate
Tidal.
I
mode.
watched him change
That's an
all of them.
accessory.
And I'm like, what?
I
Well,
turned your
that's
daylight savings on,
Thank
so
you.
you plug this in, and daylight savings come, and it's automatically gonna switch.
What
Okay.
if you
That,
live in
so-
Arizona?
Have to switch it. When you're
She
in
adapts
Arizona,
per time zone.
You would
Yeah.
change your time.
When you plug it in, it
No, they don't do daylight savings.
Ah.
Oh yeah, you're right. They
You just
don't.
keep it.
Arizona
Either
and
go
Indiana,
Florida.
right?
You turn it off. You would turn
Like
it off.
parts of Indiana.
So
and
we're
stuff.
not gonna have
I didn't
access
know
to the
that.
automatic
Was
mode
the advice
you
they-
They
yeah.
used to.
to
this
change
is-
anything because we can't
When I
take
was
the
a
neb
kid.
off in the automatic mode, so it runs.
You can
Yeah, well,
We
you
have no access in the
Daylight
automatic
savings,
mode.
not time
Clinical access,
zone.
you can do everything.
No, we do not have clinical access.
So check this out. It's interesting that
What, in
I'm gonna go
hospital,
grab
they
the
don't have
other
clinical
machine
access?
too.
Why can't you get into that?
Two.
Our machine, I don't know.
They don't trust you,
was
Shannon.
like-
No, you have a code.
There's like
Yeah, why
We
don't,
don't have the code.
no, we were never
4345.
given a code. That's
Well,
why.
there
it's
we
so
go.
hard.
You guys,
Write that down.
it's the last four of the
4345.
SN and or
It's not serial number, it's
Ah.
4345.
it's not serial number.
Wait.
The only one that's serial number is Life 2000.
Okay, which is it?
well, your
3, 4,
clinical
4, 5.
access, 4345.
Yeah.
It's not serial number either?
But it's off.
Yeah.
So you don't want it on. If you have it on, then you
I'm
have
gonna
to
go
put
get the
in the
other
code.
machine because it might be the other one.
I'm
So
sorry.
somebody
I
turned
was,
it
I
off.
zoned for a quick second. What?
Somebody turned it off.
Okay.
It's off.
So you have to turn it on, and then you have to use
If
the
you,
code.
if I have it on, see then
Yeah.
4345, enter.
Then you can go in and change your peak pressures. You could go into automatic mode. You could put in custom care plans for your patients if you guys find out you're using this regularly. You know what I mean? And it just
Right.
makes sense. It would, you know,
Right, well,
maybe
because
not
we
the
had
first
wanted
two
to-
treatments, but
So-
have like a starting point
Yeah.
and have it in the automatic, but we couldn't get in there to do anything. And also, that nebulizer is loud.
Yeah, you can turn off the net.
Yeah.
Now we
So-
can. Okay.
We usually don't do automatic in a hospital setting
Right.
unless you're so busy that nursing is doing the treatment. Otherwise, your guy is gonna stick in manual mode.
Okay.
You can do it, but when you set it up, you would set up your pressures, you set up if you want the neb or not, you set up also, your peak and how much time, you have to do individual. Once you set it, you can't go back and replace it.
yeah, you can delete it.
Well, you can
the
delete it,
care
but you
plan.
can't, you can modify it, but when you're modifying it, if you're gonna modify one stage, you have to go back into each and every one stage.
Yeah.
But in a hospital setting, we traditionally don't do that, we traditionally keep you on manual mode. I only have one hospital that does automatic, and that's a long-term care vent pediatric, where the nurses do therapy at night, cause the RT only works during the day. And then they go in and they'll pick a room number, and then they'll hit it, and then, they'll hit start and they'll see, I don't have a.
Mhm.
And that's another thing, you have to have your circuit plugged in, otherwise you get this, if you don't have your circuit plugged in, you're gonna get biofeedback error. Then you gotta grab a circuit, plug it in. Oh, this one's.
I just want to see if this. So I missed the part about the lockout thing we experienced. That's just because it was in like pre-programmed stuff, which we shouldn't use anyway?
The lockout was because we didn't have the access code.
Yeah,
Okay.
but you have it now, it's,
Mhm.
so I go into device, and then I go to control, you have to go to,
Okay.
but you have manual, that's, oh, we don't want it on, we want it off.
Okay.
Shannon, were you there with me with that blasto patient when we were trying on Osvaldo?
No, I was not.
So we put him in pressure control on the vent. And I mean, he was really, really critical, but I wasn't even getting a chest rise out of him, sats dropped.
Can you show me one
And
more
would
time
that be
how we got
because I
to
was
it?
using
So
the
it
PEP
was,
Yeah, so
with it?
I switch
In line with
over,
the vent.
Yep.
I go to
Yeah.
cog,
And then I
I
wasn't
go
I
to
was not getting a
device.
tidal volume, I was not getting
Control.
anything.
Yeah, because you're only
your
supposed
manual
to.
mode
Yeah, like he
is
wasn't
off.
breathing.
When you do clinical access, we're
It's
gonna
a
turn
one-way
it off
valve,
as
right?
well.
Isn't that?
okay.
That way you can get into everything.
And then they won't.
I
have
used,
to
like,
worry
the
about
Bluetooth
creating
keys.
anything, they
And
just
now I
start
can
going.
go-
And I put that
Yep,
in on
so
the
now I can go
inventory,
here.
and now it's when we were.
This is the
This is
last
the
one
first
if
time I
I
ever
wanna
tried
look
to
at
do
more.
it, but
Yeah.
Then I go to
yeah, I
my
was like, oh
lungs.
shit, because I mean
and
he
I
was
can
already
look
on
at
100% critical. We were bronching him
If I wanna
daily.
adjust it, then I can hit edit. If I wanna
But that's
add more,
you were
or
using
change
both the
name. If I
oscillation
wanna
and
change
the.
name, I just,
No, I used the
Um,
PEP therapy
I
on
just
it
go into it
first.
and I
Okay,
hold it down.
so you were going back
And
and
then
forth,
I
not just
will
Well,
using.
I
changes.
tried. I did
So if
that,
I
and then I
wanted
went to
them
the
to
other
do,
one,
like, a
and
Okay.
it
segment
was like.
starting with the air
Because yeah, you're
gas,
in the vent. You're
Yeah,
only supposed to
you
use
could.
the
I could do that.
CHFO.
Yep.
Not-
Right,
not
because you
zero.
already have it in
Yeah.
the pressure
No.
mode.
Yeah,
Your
you
patient
could,
already
you
has
could
it,
do
you
that.
don't need to do
But-
that, so you just do the oscillation.
Okay.
But it could have just been this patient.
Right.
Yeah.
You know, if you're moving and it's just so, if you're bronching that much and there's just so much
So
mucus in there,
defaulted
maybe
off,
it's just
okay.
plugging
Yeah,
and
but
causing
we
your
have
sats to
manual.
drop.
Yeah.
Clinical access is off.
So I
It's
know
hard
you
to
guys
know because
probably
I wasn't there.
coming up done with your lunch hour and stuff, but I do want to at some point
Yeah.
speak to you about the Life 2000, our non-invasive ventilation system for both in-house and home.
Okay.
So what's great is this guy is awesome for those patients that are stuck in the hospital on high flow and they can't go home because of that. We can try the patient here in-house with an order to see if we can get their oxygen needs lowered and get them home safely on this device with a concentrator. So your patients that we see this on are your stage 3 COPD patients, these frequent flyers that come back into the hospital, put them on BiPAP for a little while, blow off their CO2, send them back home. This guy is what you use
Manual
during
mode
the day.
access is on, so
So
you
they have a
to.
trilogy or astral to use at night, that's great, let them keep using that device at night. This is
So
for
on
portability,
means you don't
this
have
is
to
for
put in.
ambulation, this is for the other
So this
16
puts
hours
up-
of the
plug
day
that
when they
one in.
need to blow off CO2. Weighs 1 pound, it has a 4 to 6 hour battery life. In the home, it's driven off of a small compressor that attaches to their concentrator with a hose. Out of the home, it runs off of a tank. It has to have a 50 PSI pressure source to operate it. That's how we can get it so small. We can set tidal volumes, eye times, peep, backup rate, sensitivity, and then there's 3 different activity modes. So low, they just need a little volume support. Medium, maybe they wanna do their laundry and they need a little more support. They're gonna go take the dog for a walk or go to pulmonary rehab. We can set a higher support. And our RTs go out and do this. They'll titrate the patient on the device. Or if you have a patient in-house you wanna try on it, that would be me, that would come and try it on the patient.
So those 3 settings, are already preset to what they
We
need?
customize it to the patient.
Okay,
Mhm.
so that they're just pressing the
Just to
button
make
and
sure
it
you
just
have
goes
The
to
patient just
Yep.
what they need,
Yep.
okay.
Yeah, so our RTs do all of that.
Concentrator?
What's that?
Is it a concentrator? What is it?
This is a non-invasive ventilator that the patient wears a nasal interface. And in your folder, I gave you guys a whole bunch of information on it. There's some QR codes that you can scan to learn more about it too.
Okay.
And if you put your emails down on that thing, I can send you some electronic stuff too, but I think there's some clinical studies in there as well. We're having such great success keeping patients out of the hospital. Post lung transplant patients, getting them into rehab so they can qualify for
Cause
the
yeah, we
transplant.
really tried to get it on that one patient and that's the last time I remembered it.
She ended up going to UW Hospital.
For that? I don't vaguely remember.
We tried really hard to get it on her, and then she started,
It took a while
Going
for her to
back.
qualify though for it too.
They transferred, she was gonna be
not
transferred.
lung, she was
Kidney.
kidney and pancreas transplant.
But post-COVID.
Post-COVID,
I vaguely
That was her
remember
big thing, is the
this.
post-COVID.
I think
People
you were
don't
even
wanna
here for
talk
that.
during it, I'm like.
It might have